at Jersey Shore in the neurosurgical ICU with Ruth Bauman,
Yes.
a nurse practitioner there, and you got to experience other disciplines of healthcare too as well.
Yes.
All right, so I will let you take it away.
Thank you.
You're welcome.
Hi everyone, my name is Caroline. Most of you already know me. As Ms. Stevenson said, I was at the Jersey Shore University Medical Center Neurosurgical Intensive Care Unit. So this is what it looks like. This is the Brennan Pavilion. We were on Brennan 4, we're the left side over there, and then right across the hall, the only other thing on Brennan 4 was the medical trauma or medical surgery ICU. That was just a different specialty of ICUs, but basically our units were kind of mirrored. So we had a 13-bed unit in sort of a horseshoe-like shape. These aren't exact pictures from that ICU, but they do a very good job of showing you what an ICU looks like. My mentor is Ruth Bauman. She's an advanced nurse practitioner in the ICU, and her role in the ICU is interchangeable with a physician's assistant. They are both kind of in charge of the floor. They stay on the floor basically the whole time unless they have a consult, and that's kind of who the RNs answer to directly. So there's not always going to be an MD or DO on the floor. Our neurologists and our intensivists are always on call, but they may be looking at other patients, reviewing scans in their offices and things like that. So that is what a nurse's station looks like on the ICU. It's a little bit chaotic. So one of the things that ICU nurses have is really, really good communication skills because things happen very, very fast in the ICU. Those are isolation rooms. Every single patient we had, except for one room, was those types of isolation rooms with the doors that easily can slide closed. This was super important because we actually did have COVID patients on the floor when I was there, and they have to stay in the isolation room regardless of testing or whatever for 10 days after their first testing positive. Obviously these patients still need a lot of health care. They are in the neuro ICU for a reason, but we also have to treat secondary illnesses like COVID with the utmost respect that they deserve. Our floor was actually a COVID unit before I came to mentorship. It got converted just about a couple months before I came back. So they had like the air filters still there. They had all the isolation protocols still in place, which was really cool to see. So what does the neuro ICU do? What kind of patients do they take? These are the most common patients that I saw. I saw stroke patients, both hemorrhagic and ischemic, which I'll go into. There was deep brain stimulation patients. These are Parkinson's patients who are getting a procedure done at Jersey Shore's OR. I saw tumor resections, so I saw glioma, I saw some other kinds of brain tumors, and basically right after they come out from the OR, we take care of them until we can refer them back to their neuro-oncologist. We also got a lot of overflow from the medical surgical ICU. You can't predict when a trauma is going to come in and when that trauma is going to need surgery, so if we had extra beds, we would take those patients, and our nurses would be in charge of those patients just like they were their own patient. So I wanted to talk to you a little bit about strokes and how I used observational skills with MRIs and CTs. So those are basically the two types of scans that you would see for a stroke. This side is an ischemic stroke. That's when there's a clot in the brain and part of the brain tissue dies. That's the black kind of darker color you see on the screen. The white color is what what blood on an MRI looks like. So that would be a hemorrhagic stroke when part of the cerebral vessel breaks and blood gets into the tissue. Both of these are really, really bad and they're not a good thing. But that one can cause different kinds of swelling in the ventricles, blood in the ventricles. You need different kinds of drainage. There's a bunch of different tubes that we can use that are really interesting. A lot of them are pressure-based and self-regulating. So you can regulate intracranial pressure through an EVD tube. And that is just like you set up the tube to the midline of the brain with the patient, however they're laying, and it self-regulates your intracranial pressure. So it'll pump the amount of blood every hour that it needs to keep the pressure at a specific point that we like. So usually we like it between 10 and 20 for these patients. The lower towards 10 that we can get, the better. On that side is also an ischemic stroke, but the green and the red show two different types of brain tissue. So the red is fully dead tissue. It's called the core of the stroke. It's completely dead, it's irreversible, there's no way to save it. Around that is called the penumbra. It's basically a different type of dead tissue. So it's almost dead, and it's going to die unless intervention is very direct and very quickly. So when we see this on an MRI, we start our intervention right away. Obviously, it's a stroke patient, so there are certain medications that can help with that and certain therapies that we can try to revitalize most, if not all, of that brain tissue. That's basically the goal for ischemic stroke patients, so we can get them as close to their baseline as possible. So the difference between an anoxic and a healthy brain, anoxia basically means like not enough oxygen in the brain, is these tiny, tiny little dots. And so Ruth would let me look at scans and try to guess what was wrong with the brain, what was not functioning. And when you get a scan, you get like 30 different slides of an MRI. So you don't even know where in the brain the problem is at first. So you have to look through every single one of these types of slides to find what the problem is. And that takes a lot of observational skills, both on my part and Ruth's part. So I did get better toward the end, but Ruth is definitely an expert, and she could point out little anoxia points right away. They're like barely changing colors on the screen. She also was able to point out all the ventricles on the brain, and it's really interesting to see how her mind reads these kinds of MRIs, because it's a lot different from how I would have read them. So deep brain stimulation is a new kind of surgery. Most of these patients are in clinical trials for this, and it's a Parkinson patient who gets an electric node or lead put into their brain, into a motor center. So this basically helps with their motor function. That's the ultimate goal. For us, we just had them right after the initial surgery in the OR, so we would just care for them like we would any other brain surgery patient. They would go to an outpatient place to actually get the procedure done. So that's when you turn on the lead. You can test different settings, you can test different places in the brain to see what works for each patient. But it was really cool to be part of something kind of groundbreaking at the time, of learning about how Parkinson's affects these patients' everyday lives, and to see kind of the solutions that they've come up with for that. So one of my first aha moments was that I definitely want to be an RN. So the reason I did this mentorship was kind of because I wanted to see all the different types of hospital roles that they have, one of them being a registered nurse, and Ruth is a nurse practitioner. So usually to be a nurse practitioner, you do have to have experience as an RN first before you go back to school. And the RNs on the floor were actually so amazing. They had so many face-to-face interactions with the patient. They were the main point person for the patient's advocate. They're definitely the liaison between the patient and every other person the patient talks to, whether it be patient families, other medical professionals. And they were actually able to problem solve a lot more than I thought that they would be able to, because during rounds, when a doctor asks a question, it's not to the nurse practitioner, it's to the RN that the patient has been seeing. Because the RN will go in the room every 10 minutes, 15 minutes, 30 minutes, and really get that face-to-face with the patient. Mm-hmm. Some other people that I saw on the floor, physician's assistants, have the same roles as nurse practitioners in acute care, MDs, DOs, and patient care technicians. So these were basically just, they could help with basically everything. Moving patients, if we needed someone to sit with a patient one-on-one, they would be there for that. They were kind of grabbing supplies for us. They were really, really helpful, especially when we were trying to do like procedures and things like that, where you can't leave the room because you're already sterile. They were super, super helpful with that. So I just wanted to shout out some other roles that I saw. So in the red, those are the patient care technicians. Those are students, but that's what they look like in the hospital. You have respiratory therapists, which was super important for my floor because most of my patients were intubated. Physical therapists as well were really important. You have pastoral care, which really brought comfort to our patients. You have palliative care measures and hospice care, which was also very important on my floor. This man over here is kind of what our medical supplier would do. Basically, the charge nurse would just tell him everything that we needed for the week, and he would run around the hospital looking for those things, and he found them really, really quickly, which was super helpful to us. Also, you have medical transporters. These were also very helpful because we had to take patients to CT and MRI just about every hour. So it was super helpful to have another hands on deck to help us move the gurneys. My second aha moment was about the type of care. I definitely enjoyed being in an acute or critical care setting, whether it be an intensive care unit or in the emergency department. I think it tests all of your skills as a nurse or any kind of healthcare professional. I enjoyed being in the hospital setting, even though we were a specific ICU. It wasn't the same exact patient every single day. It was definitely a mix of different cases, definitely tests your brain power and your problem solving. And you can see on this picture, that's like what a patient's room would look like when you would walk in, and the nurse is in charge of knowing what all of those machines do, that they're actively working properly, and how to adjust the settings if they need help. So there's a lot of leads, a lot of tubes that are going into your patients, and so definitely test all of your skills. For example, one of the patients that I came across had just had brain surgery and his brain was swelling so much that they couldn't put his skull flap back on. So the entire left side of his brain was missing a skull flap. And this is super dangerous. Obviously, you don't want anything to hit that or to touch that. So it was super important to have a smaller unit where a nurse could focus on 1 or 2 patients at a time, because he actually had to be restrained in one arm because he himself, waking up from anesthesia, tried to like grip his head and pull things out that were not supposed to be pulled out. So that's kind of why I liked almost the intimacy that the nurses could have with the patients. They could really focus their attention on 1 or 2 patients at a time, which is super helpful. My third aha moment was the effective communication that I saw. I think communication is the backbone to good healthcare in general. And the ICU, as I said, can be very, very chaotic. I think it's a hard skill to learn the way to effectively communicate in a high stress situation, and everyone that I saw on my floor learned just that. They were the best communicators I've ever seen, and I do think it's the difference between a patient's life and a patient's death. These are very common scenes that you would see. So the bottom one kind of represents grounds. It would just be a bunch of doctors and nurses changing out different people, walking around to different rooms all the time. Orders were being thrown at people. They would type orders as they were talking, as they were presenting. They would pull up scans as they were presenting, call pharmacy when they were presenting. A million different things were happening at once, and it was all to help the patients. And I really respected that. And also, the top picture is just about consulting with the patient directly and the patient's family. Sometimes I feel like that gets lost in the woodworks of actually talking to the patient or the patient's family directly, especially when your patient can't talk back to you, isn't conscious. It's really important to have effective communication between healthcare providers and the family members, and I definitely saw that on my floor. So thank you, and I just wanted to thank Ruth too. She couldn't be here today. She's on vacation in Florida, which also sounds nice. But I wanted to thank her for being an amazing mentor and teaching me a lot of things about the hospital. So thank you.
What were like the specifics of what you had to like don and duff for the neuro ICU?
So to get into the ICU, you didn't need anything other than scrubs. To go into a room that had isolation, you would need the full gown, the bouffant, which is like the hat, gloves, and booties. To go into a room that had a sterile procedure, if you were not performing the procedure, regular gloves and the bouffant. That's it. If you were performing this procedure, obviously it's like the same thing that they have in the OR, sterile gloves, sterile gown, that whole thing. Any other questions?